is our virtual CME series session one. It's harm reduction strategies for patients with opioid use disorder with Dr. Kurt Bravata and Dr. Kento Sonata. So my name is Beth Rosemary. I'm the Education Commission co-chair and vice president of the MAFP. Want to thank you for joining us. This is the first of 10 sessions that the MAFP has planned. These will be great, convenient, interactive CME, and we hope that you'll join us for all of them, or as many as you can. We know it's tempting to turn your camera off during the virtual presentations, but we encourage you to please keep your cameras on. This gives our presenters a better feel of who's on the presentation, kind of helps keep you honest so you're not tempted to search for beach vacations, although that sounds better than what we've had the last few days. And tonight's presentation is live, so the presenters will be available for questions at the end of their talks. So if you want to drop a question in the chat as they come up, I'll monitor those and then moderate at the end. And at the end, if you want to speak up and ask a question directly, you can do that as well. So tonight's presentation is also being recorded and it'll be uploaded to the MAFP YouTube channel. The CME is only available for live attendees. Please complete the survey that Bill sent out in the email earlier, and the information entered there will be used to report your CME. So without further ado, here are Dr. Kurt Bravata and Dr. Kent Sonoda.
Hi, everyone. Yeah, so I'm Kurt Bravata. So I'm a family physician currently practicing in Bolivar and Buffalo, Missouri. I have been at Citizens Memorial Healthcare since 2013. I came from New York, which is where I was born and raised. Did my training in the Bronx and had a lot of exposure to patients suffering with addictions, particularly opioid use disorder and stimulant use disorder. When I came out here to Missouri, I did not expect to be seeing so many patients struggling with various substance use disorders. I guess I really didn't do my research. But when I came out here, I was quickly became clear that there were a lot of patients that were exhibiting drug-seeking behavior. And I started to look for options for how to treat those patients. And so in 2014, started providing some opioid abuse treatment and alcohol abuse treatment using Vivitrol. And then in 2017, it was when I got my buprenorphine waiver and then later became board certified in addiction medicine and founded a addiction recovery program here at Citizens Memorial Healthcare, which serves the surrounding community. And it's one of the fastest growing programs at our hospital, which we say that's, it's honestly unfortunate to see how fast it is growing. And we know there's an opioid crisis. So I'm going to let Kento introduce himself, and then we'll continue with the presentation.
Great. Thank you so much. Thank you so much for joining us tonight. My name is Kento Sonoda. My pronouns is he, him, his. I'm one of the faculty member at the St. Louis University, and I'm serving as a addiction medicine fellowship faculty. So my journey around addiction medicine started when I get into HIV tracking residency. And as you know, there are two ways to get the HIV infection. One is sexual contact, and the other one is the substance use. And when I felt very comfortable to talk about this, sexual history and around that history, but even at the end of residency training, I didn't feel comfortable to manage the substance use disorder and also manage the challenging conversation with patient with substance use disorder. So at the same time, my former institutions just launched addiction medicine fellowship. So, and then they're just looking for internal resident. And so I felt like it's a perfect timing to get into the fellowship. So that's how I get into the addiction medicine fellowship in PA State. And then I did that and I loved this so much. So I wanted to serve as addiction medicine fellowship faculty member. That's how I found St. Louis University and I joined it. Then it's my pleasure to foster the future addiction medicine doctors and also work with medical students and the residents interested in addiction medicine. And around the line, I love to foster educational experience for those who don't have like expertise around addiction. So I'm serving as a Midwest Society of Addiction Medicine Education Committee Chair, and also I'm doing the Curbsider Addiction Medicine Associate Editor. So you please check out the podcast whenever you can. So that's me. Thank you so much for joining us today. So I give
Yes,
back to you,
and
Dr. Bravada.
thank you, Kento. And I do have the pleasure of serving alongside Kento with ASAM as the Midwest Regional Secretary. And I'm also Vice Chair and co-founder of the CMDA. This is Christian Medical and Dental Association's Addiction Medicine section. So our learning objectives today, number one, are to appreciate the scope of the opioid abuse crisis. Number two, to understand the basic concepts of harm reduction. Number three, to become familiar with the principles of opioid replacement therapy. And so we would just like to ask at this time that everyone have their mics muted and not have any other electronic devices on, and that we be cordial and respectful of each other as we communicate through the chat. Neither Kento nor I have any conflicts of interest at this time. So let's talk a little bit about epidemiology. In the United States, 5.6 million people age 12 or older in 2001 suffered from opioid use disorder, and the predicted number of deaths between July 2022 and June 2023 was as seen here on the screen. And let's see, so you can follow the graph here. I think this was one that Kento added. Do you have anything you want to speak about regarding the graph here, Kento?
Yeah, thank you so much. Yeah, so basically the predicted number of death has been increasing and in the United States, and that's why it's critically important to understand how to treat the OUD nowadays. And then I'm going to touch on the local data now.
Thank you.
Okay. Oh,
go ahead.
So this is the local data in state. So as you see for the past 5 to 6 years, the number of all drug overdose death has been increasing. 2023 data are not available as of today, but as you see in 2022, the total number was 2,180 deaths from the drug use. So it's been worsening. So we need to stop this trend. That's why we are here to talk about it. Next slide. So this is the local data, and as the color gets darker, there are more overdose death, and so as you see, so the St. Louis region is the worst, and then Kansas City area be the next, and then if you look at the county levels, so there's a St. Louis on the right side, there's St. Louis County and St. Louis City region. And then the other area is a kind of darker, and the dark purple color is Jackson County around the Kansas City area. Next slide. So this is the numbers from top 1 to 10. It's kind of very unfortunate, but the top two are in St. Louis County and St. Louis City. But the third top is Jackson County. It's around the Kansas City, and the fourth one is Greene County, which is around the Springfield. So, look at the where you live, but the this is what we have in Missouri. And it's important to understand the epidemiology and the numbers based upon where you live, because that's you're happening in your community. Next slide. So the question is, should we treat OUD, right? Yes. So we already seen that lots of patients with OUD in our practice, and I'm pretty sure you have prescribed opioids for the chronic pain. And so I'm not saying it's a bad thing, but just as a matter of fact, 75% of those who began their opioid misuse in 2000 reported their first regular opioid use was a prescription drug. So it's coming from us. And I think it's just a fact. And I see that many patients who got injured or got the surgery and they started on the opioid, and then they had like a little bit of leftover and kept it, or then took it a little bit extra and then they felt good and they wanted to keep taking it, or they started on opioid and they still wanted to stay on the opioid, but I think the physicians stopped it because I think the acute phase was ended, but the patient still wanted to take it, so started to seek out the drugs from the community, and then escalated into heroin or fentanyl. That's pretty common pathway too. But just wanted to highlight the factor around the opioid prescription from us. Next slide. Yes, so again, treating OUD saves lives, and I wanted to touch on a couple of stats too. Next slide. So, harm reduction, this is our title today, but the use of opioid agonists, methadone and bup, reduces the overdose, illicit drug use, and transmissions of infectious diseases like HIV and Hep C. And those with medications as a part of treatment are 75% less likely to die due to substance use disorder compared with those who didn't get it. That's a huge. So it's we don't have that effective medication other than opioid agonist, and so it's a really effective medication if we use the medication for the appropriate patient populations. Next slide. So, and also it's cost effective and it's good for reducing crime too. Every $1 invested in substance use treatment returns a yield of $47 in reducing drug-related crimes and criminal justice and theft. And, the addiction treatment may not, create lots of financial benefit for the clinic, but that would save lots of money and the financial that can save the financial cost in the future. So it's more so preventive services. Okay, so just a little bit of education around the language. I often hear the term MAT, which is stand for medication assisted treatment. It's often used for like basically like a medication for SUD, but it's more accurate and appropriate to say medications for OUD, because the medication is not necessarily assisted, it's a medication. So the MOUD, whereas as called medications for OUD is more appropriate. And so patient can learn healthy coping and life skills, and also they can get the job once they get situated, and also they can take care of family and engage in medical and recovery care. So all good once they get situated from the treatment. Next slide. And also, it's important to understand as a fine medicine doc, SUD is a chronic disease. There is nothing special other than compared with other chronic diseases like hypertension or asthma. If you look at the prevalence and how common it is, like it's we should take the CD as a part of the chronic conditions, as you see on the graph. Next slide. And again, OUD is a chronic disease because everyone is susceptible to develop OUD. Yes, there are some risk factors and there's a genetic components too, but it can happen to anyone. And so, you may not realize how common it is, and we cannot tell from the appearance. And something happens in life, and many patients never thought of getting the OUD in their lifetime. I have a couple patients, like someone, like one of the friend was using and then just tried it one time and then couldn't get out from it, and it just a one-time use can change the life. And I have the other patient, he's like 18 years old, and he just tried it one time and then he had overdose. And so just one-time use can um, affect the life. And so it's important to remember that the OUD can happen to anyone. Next slide. And also treating OUD reduces the disease spread that can improve the HIV incidence, Hep C incidence, and also that can reduce the IE incidence too. So all good. It's great treatment. Next slide. Okay, so this is something I love to talk about, and this is something I uh, gave a lecture at the last year annual conference for the MAFP. But there are lots of factors leading to MOUD stigma, and I want to share some of those. So framing of SUD as a willful choice, not the disease. So it's not in many situations like it's not the matter of their weakness. It's a disease. So it's there are lots of misunderstanding around it. And and also it's very common that the SUD is being treated as a separate treatment from the primary care. And that's why it's important to integrate SUD into a part of primary care. And also there's so much stigma language around it. For instance, like junkie or like a dirty urine or something like that. And so it's so important to utilize the appropriate language in the field of addiction medicine. And also justice systems, lack of recognition for MOED as an option for medical treatment for individuals with SUD. And that's why I'm being involved in the advocacy around addiction medicine, and as a system and as a whole, as a state, it's important to tackle the justice system and uh, healthy inequity around the MOUD and OUD. Next slide. All right. So this is a fun part, and I like to hear from audience. And what do you think about the harm reduction, and what kind of image you have around addiction? Harm reduction. So it'd be great if you can type in the chat, or be great if you can unmute yourself. Again, this is safe environment, so it'd be great if you can share whatever you think, and you cannot go wrong with it about this question.
Well, this is Miller. I'll start.
Thank
I
you.
really like your inclusion of harm reduction to include reduced HIV, Hep C, and infectious endocarditis. I hadn't really thought about that. I know it's out there, but that's a really good point.
Thank you so much. Thank you so much. Yeah, so addiction involves, lots of aspects, right? So just not the OED itself, it involves infectious conditions too. Thank you so much for touching on that. And also I got the comment, more effective than abstinence. Yes, thank you so much. Harm reduction equals aiming for risk reduction as opposed to perfection. Yes. Thank you. Okay, great. Thank you so much. So, oh, and I got another comment. Thank you so much. Concept that cure and abstinence are not the only positive outcome. Yes. Yeah, so the many of us and I sometimes do like tend to look at the abstinence as only positive outcome, but we need to be uh, cognizant and mindful of uh, take breaking out the steps into bit more smaller because it's far out from daily use of fentanyl to recover like abstinence. And also not everyone has the same goal. So it's important to check with the patient and then what they're at, and then we need to respect what they want to do. And this is a definition from SAMHSA. So I want to uh, read some of the main points, but basically SAMHSA defined harm reduction as practical or practical and transformative approach, and that incorporates the community-driven public health strategies and to empower people who use drugs and their families with their choice to live healthy, self-driven, and purpose-filled lives. And also, it's important to note that these strategies and the practices that flow from them. So as I mentioned a little bit, it's it's on themselves. It's not from us. It's up to them, and it's the key point is to uh, understand that this concept is coming from the patient lenses, not from our lenses. Next slide. Okay, so
The blank slide.
next, yeah. So this is uh, the one that I want to share with you. So, Dr. Bravada, can you stop sharing and then I will share my screen?
Okay. If I pause share, will that work?
No,
Yeah,
you need
stop.
to stop. Yeah.
Okay.
All right. So this is a YouTube and I hope you can hear this. Can you hear this? Okay, good.
As far as engaging people around overdose prevention, now I'm talking about opioid use or people who are using opioids, I find it's more helpful to talk to them about what they're going to do when they see someone else overdose. It's also important to talk to them about the concrete steps they're going to take when they overdose. But I think that a lot of people are motivated to change their behavior based on what they've observed in other people. In my personal experience in talking to patients and their families, an overdose is more traumatic an experience for the person who observes the overdose than the person who experiences the overdose. Most overdoses, people are revived and they feel okay afterwards and they don't even remember what happened. But for the person who's there witnessing it, that can be very traumatic. And that's why when I talk to patients, I ask them about their own overdose experiences and I ask them about the overdoses they've witnessed.
Right. Great. Thank you so much. Can you back on the slide? So now the key is talking about, how impactful it is, the overdose it is for the patient with OUD. And so it's important. I just wanted to share kind of the aspect from one of the national leader. And so now I like to share some of the supporting principles around the harm reduction. First of all, it's really important to respect the autonomy. Again, I want to respect what they want to do. That's why I always ask with a patient, what is your goal? And what do you think would work best for you? And unless like that would harm the patient, I will respect what they want to do. Because if you just force what you want to do, they may just say yes in front of you, and then they may not come back in front of you. So that's why, to me, the respecting autonomy is critically important. Next one. Uh, then cultivate the relationship. It's kind of related to the autonomy piece, but to me, relationship is critically important. It might be the most important one. I want to make the patient feel like this is the home, a safe home that they can come back. When I see the patient as a first visit, they are super motivated and they feel like they can do it, but it's not that easy and they may not be able to come back. But at least I like to be the home for them and to come back whenever it's ready for them and they want to commit themselves to the treatment again. And so I say, no matter what happens, please come back and I'll be here to assist you. And then lots of patients come back and request me to see them. And that's why I think having the good relationship and having rapport is critically important. Next. And then assist, not direct. It's kind of similar with autonomy, but it's not assisting or directing not directing the patient what to do. It's a matter of how to assist the patient, what they want to do. Next. And then promote the safety. It's a piece I'm going to touch on later on, but if they die, we cannot save or help them. So it's one of the most important piece to emphasize whenever I see the patient. For instance, I ask them like, when you use the drugs, do you use it by yourself or do you use it with others, or do you have need a narcan at home or something like that? And then if they don't know, like any like apps that they can use, they can never use alone or the Brave app, those app can for instance, if they turn on or use that app and someone be with them anonymously, and then they will keep checking with them, and then if they stop responding to their communication, the 911 be automatically called, and then GPS is tagged with the app, so that 911 be called and they be rescued by the EMS, something like that. Next, and then prioritize listening. Again, to respect what they want to do and cultivate the relationship, you need to listen. Yes, you have tons of things you want to say to the patient, and those patients tend to have lots of medical conditions, but you need to be, step back a little bit and then be patient and need to prioritize and be patient with listening what they want to say. I think I got the comment. Could you name those apps? Yes, I will never use Dawn or the Brave. I have a Brave one in my phone, and I always share with the patient. All right. So now I just want to check with the audience again. What can we do to practice the harm reduction? So it'd be great if you can share some of the examples that you can think of for the harm reduction strategies. I kind of named it a little bit, but you can type in the chat or you can unmute yourself. Okay, thank you so much. So create the agenda for visit together. Yes, thank you so much for your comment. Yes, and it would be great to have more time in message. Oh yes, someone said they wish they have more time to spend the needed time. Yes, thank you. All right, so there's nothing like clear cut the right answers, but let me share some of the practice strategies that I thought of. Next slide. So first off, the motivational interviewing. So basically, it's kind of respect the autonomy and then kind of enhance their internal motivation, and then it's driven by their motivation, and that's a skill I think I always use and I talk about with learners. And again, yes, you want to make sure they have access to Narcan just in case, and not necessarily just for them. It's a very common that they tend to observe or encounter the overdose situations. So I would just generalize that, you know, it's important to carry the Narcan and so that you can save others. And I say that for myself too. I have Narcan for my in my bag too, and so that I can save others. And also, if there is, syringe exchange program can be used as a tool for harm reduction. When I was in the PA state, I served as a wound care provider and a physician at the one of the syringe exchange program in Pittsburgh, and it was very rewarding experience because many patients are not ready to stop using drugs, but they're ready to talk about like, where to inject or how to inject or how to use it. Like instead of using IV, they are interested in using from other sites or something like that. So it is very rewarding experience to for me, like how to talk about it. And then the other piece is like I said like plan A, B, C. That what it means is that you would ask with them like what do you want to do and what just in case when you get triggered, what do you do? And then they may say, okay, I will take a deep breath or something like that. I will call that strategy as a plan A, and but it may not work, right? Then I would challenge them again. Hey, if if that doesn't happen, what do you do? Which is plan B. And and then I kind of keep asking them like till the plan C sometimes. And in that way, you can like build up the more reliable and reliable plan for the patient to prevent against overdose. And then again, as I mentioned a little bit, I talk about the overdose detection app to the patient too. Okay, and I think I got the comment. Oh yeah, buy and carry the resuscitation mask with one-way valve. Yes, yes. Thank you so much for sharing. And also I wanted to share one of the good resource for the patient and your knowledge. This website was developed by mainly by Yale School of Medicine addiction medicine team and also podcast addiction medicine Cubsider team members. And I thought that this website is very helpful, and I posted the link on the chat. So you can use that and this website for your learning, and also you can share this link with the patient or health staff member to learn more about the harm reduction tools and a safer injection. Okay, so I think this is it from my end. But
Right.
if you have any questions, I'm happy to take it then. Thank you.
All right. Thank you, Kento. So we're going to talk about OUD treatment options. And one thing I'd like to say just starting off here is that, although we're employing science here, through the medications that we prescribe. And, we talk a little bit about this, the science that goes behind that. There really is an art to OUD treatment. And so I know sometimes providers who are interested in getting involved in providing OUD treatment, they want specifics. And so we'll provide as many specifics as we can, but this really is a brief overview. But for those of us who have been in it for a while, we've recognized that there really is patient-driven strategy is really what it comes down to. And so you have a patient that comes to you seeking treatment. And so they may be actively using, they may be intermittently using, they may not have used for a while, and they're just wanting you to help them stay sober. And so you have to start there. What is their substance of abuse? Is it one substance? Is it multiple substances? Are they actively using? If they're actively using and they're intoxicated, do we have to detox them? And can they detox in the outpatient setting, or do they have to be in the hospital? And it really comes down to what their substance of abuse is. For stimulants, methamphetamines, cocaine, that you really don't typically need to hospitalize them unless there's some psychosis or delirium. Benzodiazepine and alcohol withdrawal may require inpatient detox, and that would be based on their CWAS scale, or just their general presentation in the office. For OUD, although you may feel like you're dying, typically, the side effects of opioid withdrawal are typically not life-threatening. And so those typically can be done in the outpatient setting. And so now you want to provide counseling or peer support. So in my practice, we have a counselor. We also have a peer recovery specialist who is someone who actually recovered in our program. And now she helps other patients by meeting with them in the office, doing some group visits, connecting with patients in the emergency room, in the birthplace, on med-surg, and also calling patients to follow up with them and see how they're doing. And sometimes if a patient calls in and they're struggling, we'll just connect them with our peer recovery specialist. And she does such a great job one-on-one talking to them, because she knows where they're coming from, because she's been there too. So now as treatment providers, we can provide counseling ourselves, but it really is helpful to have a behavioral health specialist provide that service as well. And that could be a licensed practical counselor, an LPC, which is what we have. We also do have psychologists through our psychiatry behavioral health department, and we have LCSWs that we can also refer to. So buprenorphine is more commonly being used for opioid replacement therapy than any other, than methadone, although traditionally methadone had been standard of care for opioid replacement therapy, but really buprenorphine has been found to be much safer. It is a partial agonist at the mu opioid receptor, and we'll talk a little bit more about that. And that can be prescribed or administered through an office-based opioid treatment program or a certified opioid treatment program. Now, for methadone, that currently is you're only allowed to prescribe that. You can prescribe it in emergency situations, you can prescribe it in the hospital, or you can prescribe it, which is really being administered and dispensed through the certified opioid treatment program. But there's some legislation and definitely advocacy behind that to try to make methadone available through the office-based setting. Naltrexone is an antagonist at the mu opioid receptor, and this one is available in the oral form and also in the depot form. It's a good place to start for those who are a little hesitant to start buprenorphine because it's non-opioid, non-habit forming, really no major risks of side effects. The only major medication interaction is with opioids, although it does block some of your natural endorphins, which are released, like your beta endorphins, which are released when you drink alcohol. So you want to consider the effects that it has for someone who's using alcohol. But it's very, very safe. And you may want to consider caution in someone who has liver failure. Um, so, and referral to short or long-term residential treatment. So this is going to be for the patient who potentially has detoxed in the hospital, someone who's a heavy user, oftentimes for alcoholics, or for someone who's failed outpatient treatment. And for someone in that scenario, you may want to refer them or direct admit them to a residential treatment. So we're talking here about OUD treatment approaches and rates of adherence. So as you can see here, there's some similarity between buprenorphine and methadone in terms of rates of adherence. And that's because opioid replacement therapy works for OUD. Naltrexone, a little bit less so. And there's different reasons for that. You know, it is available in the depot form, and so that lasts at least 30 days. And for those patients, if you can get it administered, you know, they're going to do fairly well, but it's hard getting them to come in for the injection. And then if you're prescribing it orally, they have to remember to take it every day, and they don't really experience much positive benefit from the medication itself. They don't really feel like they're taking anything, you know, after that first dose. And so they don't really feel a strong motivation to take it. For detox and then abstinence. So these, you know, this is where we kind of talk about abstinence-based programs. And, you know, although there is a place for it and there is a particular type of patient who's ready for that type of abstinence-based program, someone who's highly motivated, maybe someone who's not a heavy user, someone who maybe hasn't used in a while and they just had one relapse, something like that. You really want to take advantage of the medications that we have because you're going to significantly decrease their relapse and you're going to improve their rate of adherence to programs. And someone who's on a medication that blocks those opioid receptors, they are much more likely to, well, they're going to be more clear-headed, they're going to be less anxious, they're going to not have that drug-seeking behavior, and they're going to be more likely to want to engage in the behavioral aspect of recovery. So you can, this is just kind of reiterating that point. You can see here on this graph, you have the x-axis, which is your months in treatment, your y-axis, which is the percent of adherence to and retention in the program. And so then you have your green line there, which is opioid negative for the past month, and then the blue line still in treatment. And you can see that as you progress in time, those who are on opioid replacement therapy with buprenorphine are more likely to stay in treatment. So here's some good news. And we definitely think it's good news because we need an army of people who are providing opioid replacement therapy through their practices, that you don't need an X waiver to prescribe buprenorphine any longer. And this is a really important point because I know for me and for many doctors, for many mid-levels who are considering prescribing buprenorphine, just the very concept that you need to have a special X waiver to be able to prescribe it created this stigma around buprenorphine, and it created a fear factor that you need some extra training because it must be dangerous. It must be a scary medication because, you know, precipitated opioid withdrawal, which everyone's afraid of, you know, am I going to put a patient into withdrawal by blocking those opioid receptors? You know, is that going to, you know, cause the patient to become violently ill in the office, or is there going to be diversion, all these different things because of that X waiver? And the other thing is that this idea that because there's this DEA X waiver, that the DA is going to come and storm your office because you're providing opioid replacement therapy. And now that they've really gotten rid of that, I think we're going to see a lot more people getting involved in addiction treatment. And I really hope so, because it's really something that we need. Um, so, uh, so buprenorphine. So buprenorphine commonly comes in a form combined with naloxone. And we're not really talking about name brands here because we're trying to avoid that, but many of you will recognize the name brand of the form most commonly prescribed that's formulated with naloxone. And so something to understand about the naloxone is the way it is formulated is that naloxone molecule is not significantly absorbed into the bloodstream through the GI tract or sublingually. Now, that doesn't mean that you won't get some naloxone in your system, but the point is that naloxone, which causes opioid withdrawal and is used, in the case of overdoses, if that is to get directly into your bloodstream, you are going to go into opioid withdrawal if you're on an opioid. And so the first thing you need to know is that when you're taking buprenorphine combined with naloxone, it's the buprenorphine that's being absorbed. Okay. Now, if someone tries to dilute it, melt it down, melt the medication down, and then inject it into a vein, then it's going to end up in their bloodstream, and that is going to put them into opioid withdrawal. So that is why it is formulated that way. It's to be a deterrent for IV drug abuse with this medication, and to try to decrease its street value because they can't use it that way. Now, you can prescribe buprenorphine without naloxone, and there might be some reasons why you do that. One might be insurance preference for the medication. It might be because the patient that has been taking it with the naloxone doesn't, has some intolerance to the preparation, the film. Some people really have a dislike to the gel-like substance that forms when you stick it under your tongue. Others might say that they experience they experience some negative side effects from the naloxone, which if you check their drug screen and there's some naloxone in their drug screen, they're absorbing some of it. I know technically that's not supposed to happen, but I definitely have seen it. Although you do have to be careful that they're not falsifying their drug screen by dipping their buprenorphine naloxone strip directly into their urine. And you can tell that by levels and the creatinine and some other things that can help you understand if there's an adulterant in there. If used correctly, the buprenorphine is going to help treat their cravings, but it's also going to treat their withdrawal. So if they come into the office, they're in withdrawal, and that's the thing. When you start it, they need to be in some level of withdrawal. Or the other way is that they have not used an opioid for enough time that the risk of precipitated withdrawal is not a concern. But let's say that there was someone who they used yesterday, 12 to 24 hours ago, they'll probably be in mild to moderate withdrawal, and you can start them on a sublingual dose. If they haven't used in a week, you really don't have to worry about withdrawal. If it's been a few weeks, a month, you may want to consider whether this is the right medication for them. But if they're high risk of relapse and they have done well on this medication before, you may want to get them back on it. You do want to consider that this is it's a synthetic opioid, so there are some drug-drug interactions, but not a ton. But you want to think about interactions with opioids. You want to think about interactions with benzos, with sedative hypnotics. If you go to prescribe this, your EMR, if it runs a drug-to-drug interaction, it might give you an interaction with methamphetamine or with amphetamines, like your ADHD meds. but really they're doing opposite things. One's a stimulant, one's going to be more of a sedative. So you don't have to worry about that too much. The average daily dose is 16 milligrams. And we'll talk a little bit more about how you get to that dose. Rarely up to 24, but you may, and someone who has chronic pain or who just is, who pain is driving their opioid use, so they may need a higher dose, or they're just not. They were heavy users and they're just, or they're high opioid metabolizers, so they're not getting the benefit that they need. We say that there's a hard stop at 32 milligrams, but there's some research regarding whether or not that has to be a hard stop. And, you do have to kind of use your judgment. Like heavy fentanyl users, sometimes they can be very difficult to treat. So it's important to note this drug is safe. What I like to say to anyone who has prescribed opioids in the past, if you've prescribed opioids, you should not be afraid of buprenorphine. I mean, if you had a bad experience prescribing opioids, maybe, but if you prescribe opioids and you do it on a regular basis, you should not be afraid of prescribing buprenorphine. In fact, you should feel much more comfortable prescribing buprenorphine. And it doesn't take more than 1 to 2 patients. You just have to start somewhere, and once you do, you're going to feel you're going to be really convinced that this is a good medication. Encourage your patients not to be mixing with benzos or alcohol, but I have to say there are some patients who are benzo dependent, and you may not be able to get them off their benzo, but you just have to really proceed with caution. It does raise serotonin levels. And so some patients do say they feel like a little more energized, and that, you also have to think about is, the dopamine agonist effect, and that there's a dopamine deficit in those that are suffering from addiction, and they're self-medicating to treat that in many cases. And so it does help level out their dopamine levels. Patients do not typically, I'm not sure I 100% agree with this statement, although technically patients don't build a high tolerance to it. I would say that for the most part, patients do get on a stable dose and they'll stay on that for a long time, but sometimes they do need their dose to be increased. So as far as with the elderly, it's less impairing. It's cognitively impairing, less fall risk, less problems with decision making, less likely to exacerbate, some of their cognitive issues. We definitely have patients who are in their 70s that are on this, not too many, but I do have some. Does not affect the QT interval, which methadone does. So methadone can cause cardiac arrhythmias. So you have to keep that in mind with methadone, but for buprenorphine, less likely to have that problem. So it's safe in renal insufficiency or renal failure. It does have some effect on the liver, but really, I've never really had a situation in which I had to stop buprenorphine because of a liver issue. It's easier to wean than other opioids. I mean, I have patients, they run out of it and they don't experience severe withdrawal. They might feel increased cravings for opioids, but they tend to not have any severe withdrawal symptoms. So we talked about, this is more, in some ways, more of an art than a science. And the science to it is, start low, go slow, but also allow the patient, especially if they have used buprenorphine before, they kind of know how much they can tolerate, and they can titrate up on their own very well. And many of them have taken that first dose on the street on their own without any doctor to guide them. It happens all the time. So home inductions are totally, I don't think we go into that really here, but you can do home inductions, especially for a patient who, during COVID, we did that a lot more via telehealth. And there's scenarios in which patients, they're not able to get into the office. But typically for that first visit, you want to see them in person. But there are scenarios in which, maybe you haven't seen them for a while and they're like, Doc, I really need to get back on my buprenorphine. You might want to send them a prescription. And so your goal is to titrate them to a point at which they're not experiencing withdrawal symptoms, where they have no or minimal cravings. And then you don't want to titrate them up to the point where they're having side effects. And there's something that, people who are family members of patients who've been on buprenorphine or methadone, they say, oh, yeah, they're always nodding off. They always seem drugged. Well, that's because I always tell, family members, or others who say that they feel like people with buprenorphine seem drugged. A lot of times that has to do with doctors prescribing too high of a dose too quickly, or the patient's mixing it with benzos, or they're mixing it with alcohol, or they're not even taking their buprenorphine and they're on some other opioid. So you just don't know. But if you're prescribing appropriately, they should not seem cognitively impaired. And if they're taking it appropriately. And your goal is, this is the harm reduction side of it, is for them to discontinue or markedly reduce use of other opioids. And so this is where you're going to have to use your own judgment, because there's going to be times where, you're going to find out that they went ahead and got something on the street. And is that the point at which you say, should I be, continuing to give this patient this medication? And if you develop a relationship with them and you can communicate with them, or you can have your peer recovery specialist or social worker or counselor talk to them, and you feel like that they have really bought into their recovery and they just had a slip up, you really don't want to stop treatment. That's like the worst thing you could do, because imagine if they had that slip up and they didn't have buprenorphine, they might have continued to use heavily and then overdosed. And so the greatest harm reduction is to save a life, but also to have them, engage in recovery, to take care of their families, to be able to go to work, to be able to start taking care of their health. That's one thing that we really don't, you don't think about a lot. These patients are not receiving primary care when they're seeking drugs. Once, and they could have festering wounds, all these different things, and they don't even seem to care about it because they're just thinking about their drug. So typically you start with 4 milligrams. If you're really, really nervous and it's your first patient, you might do 2 milligrams. But in most cases, 4 milligrams is totally fine for just about every patient. So you can do a home induction, but ideally you want to have them in the office. You give them that first dose. You tell them to hold it under their tongue until it's dissolved. You recommend that they don't swallow until it's dissolved. You might tell them to put their chin down so that it's not, because whatever you're swallowing is very little of that is absorbed into your system through the GI tract. So you want to wait. So after that first dose, ideally you want to wait, 1 to 2 hours. So they say about 90 minutes. Kento can talk about some of his tips maybe after this, but sometimes you are strapped for time and you may not have that amount of time, but I do think it's ideal to do that. And then, if they tolerate it fine, you can titrate up. Now, you may not titrate them all the way up to 16 milligrams on that first day. You're going to give them some medication for them to take home on that first prescription, or you might send them to the pharmacy to pick up additional. And you tell them, first day, let's try not to go past 16 milligrams. You may not need that much. Wait every couple hours to see how you're feeling. Maybe wait 4 hours, see how you're feeling. If you're experiencing continued symptoms of cravings or opioid withdrawal, take another dose. And then over the next couple days, maybe you're getting up to 20 to 24 milligrams, but you really don't need to. That's only if symptoms are continuing. See the patient back the next day, see them back, in 3 days. The main thing is you want to see them back as soon as you can. This is a really important point. How long should someone be on buprenorphine? And I hate to say indefinitely, but that's kind of the answer. The answer is as long as it's helping the patient. So when you start insulin on a patient, a patient's going to say to you, well, how long, doc, do I have to be on this insulin? And you're going to say, well, as you may be on it your whole life. If you lose the weight, in a type 2 diabetic, if you develop the skills to be able to, control your diet, increase your exercise, all these lifestyle modifications that you can do to get control of your life, yeah, maybe you'll come off the insulin. It's the same way with buprenorphine. If they can get control of their life and they can change their habits, they can change their environment, because that's a big thing. What are the triggers around them? If they're around the same people that they've been using with, if they have the same temptations around them, if they have, a lot of stress in their life, which might be a trigger for them. There's so many different things. If they're going through a divorce, if, um, holidays, certain anniversaries, things like that are big triggers. You know, definitely get them through that first year, and beyond that, I have patients that I've been seeing for years, and we just talk about it every visit. Is this still working for you? Are you thinking about decreasing your dose? No, doc, this is really working well for me. I feel great. I've never felt better. Why would you decrease it? It's like arbitrarily decreasing insulin when it's, I mean, of course, you get them on a GLP-1, you might want to take them off their insulin, but so far we don't have another solution other than MOUD for opioid abuse disorder. So let's see. Let's go. Okay, so I think that's pretty much all I wanted to say there. So I think we have some questions in the chat, and Kento, since you've kind of probably been looking at them, let's see.
I don't think we have like a
No
question at this point. I made a couple comments.
Okay. Okay. So I don't see any.
No, we just got the question.
Yeah, there is a question in the chat.
Okay. So could you?
We are past 7:30, so
Okay.
just want to be mindful if people have to leave that.
Yeah. So if anybody has to get off, that is totally fine. So question here is, could you comment on the use of buprenorphine alone or okay, so or with naltrexone? So it'd be as far as buprenorphine, so you definitely would not use it with naltrexone, but buprenorphine with naloxone. You so now Kento, do you want to speak to this? Because I think I did address this somewhat, but if you might have another perspective on that question.
Yeah, for the chronic pain one.
So could you comment on the use of buprenorphine alone or with it's naloxone, I think is the question.
Yeah, sure. So I think when someone have like a OUD and chronic pain, I use the bup over naltrexone because the bup can help the chronic pain. Actually, this is a great comment because I just wrote the article for the MAFP Physician magazine at the last issue, how to address the chronic pain in patients with OUD on buprenorphine. So exactly the same topic that I just wrote in the article. But anyway, so when someone have a chronic pain and when you use a bup, instead of the BID, it works if you spit out. So let's say if someone taking 16 per day, like an 8 milligram BID, I often do like a 4 milligram QID instead of 8 milligram BID because the bup works for like 12 hours or so for craving and withdrawal symptoms, but it doesn't work well for chronic pain because of half time. So I use the 4 milligram QID instead, and that works pretty well. And I can quickly touch on the methadone one too. Uh, when would you want to consider methadone instead? That's a great question. I think when we start MOUD, I talk to the patient, hey, there are mainly three medications for OUD: methadone, bup slash buprenorphine, and naloxone, and naltrexone, and kind of explain like how it works and what are requirements. I think that many patients don't know what they have to do around the methadone. Typically, they have to go to methadone clinic every single morning for the couple months, and then it takes time get to the therapeutic dosage for them. And for those who have transportation issues, it can be really challenging to go to the methadone clinic every single day for a couple months. And that's a common misunderstanding around the methadone. But as long as they understand what they need to do with it, I think methadone works pretty well for MOED. So I think it's a matter of expectation and making sure you be on the same page with the patient when you talk about the MOED.
Mm-hmm.
Thank
And
you.
so I'll answer Brad's question here about how to handle opioid replacement therapy around surgeries, dental procedures. Do you continue it or taper off prior? Also, how do you get our fellow physicians and APPs to join us in treating OED? So I think there's different guidelines on whether you should taper or how long before a procedure that they should stop the medication. It also really has a lot to do with the conversations you're having with the surgeon, because they're going to want to know, and they're going to have some anxiety about the patient being on that medication unless they're very familiar with them being on it, because they don't want it to interact with anything that they might prescribe. But from my perspective, I'm thinking a lot too about, are they having a pain issue prior to surgery? Is the surgical indication painful? Are they, did they have an injury? Do they have some other underlying condition that's painful and they need, some sort of pain management? So the idea of just taking them off of their medication, like a week before or something like that, it's really not feasible, because one, you don't want them to use an overdose prior to surgery. Two, they might have pain, and so you don't want to just stop it. So some of the guidelines are saying, like, 2 to 3 days prior. I know some surgeons will allow the patient to take it up to the day before, and then some will allow you to use it post-operatively as the pain management. Now, it may not be adequate if the surgery, is very extensive and they're going to need some significant pain management. That's a scary prospect for those of us who understand the risk for a patient who has opioid dependence, because you're basically going backwards. And so if they're going to be put on, hydrocodone, oxycodone, morphine, hopefully that's just in the inpatient setting, and then you can transition them to buprenorphine. But ideally, if you can just, go as close up to the surgery date with the buprenorphine, maybe taper down slightly, just so that when you so that post-operatively you have room to titrate up. But you would only do that in a case where they're already on a pretty high dose. But in most cases, you use the same dose right up until surgery, and then you use the medication post-operatively if you can. Did you want to respond to anything, Kento?
Oh, yeah, thank you so much. I type on the chat, but I typically recommend them to stay on the bub, and because I just personally have seen there's so many patients who relapsed after being discontinued on the bub, and I think at least in my experience, I can manage their pain control with using higher dosage of opioid or using non-opioid management too. And also, if they are in the hospital, they can use the nerve block or ketamine drip or other pathway of the pain management. So that's my.
Yes, I agree with that. And then as far as getting other, like mid-level providers or other physicians engaged, I think it really just comes down to showing them, it's education, showing them, that you can do it, that they can do it, bringing them into your process, letting them shadow at your office, offering to provide preceptorship, and really just being a mentor, and maybe if you've started a program within your hospital system, let them come work for you part-time. I mean, that's what I've done. And actually I have one nurse practitioner that's full-time in addiction treatment. I have another one that's working part-time, and I have others that ever since I've started now have expressed interest. And so I think it's really just showing them it's not something to be afraid of.
Yeah, and also I just want to quickly share the one of the good program. The PCSS Providers Clinical Support System has a mentoring program for MOED. So if someone needs the mentoring for their growth above and beyond, online courses, there are fantastic educational materials available, but sometimes APP and we have a little bit complicated questions. So this mentoring program can help you address those a little bit of complicated cases, and someone would mentor you. Thank you.
Yes, I actually used that program when I got started a few years ago, and
Okay.
he connected me with a doctor over in North Carolina who was just so pleasant to talk to on the phone. And then I ran into him at a conference, and it was so cool. I was like, I had never met him in person, and I knew who he was right away. So, well, thank you very much, everyone, for attending, and please feel free to email us. Our email addresses are here somewhere at the end. So we have some resources here. We did make the slides available. So, but definitely you can utilize all these resources. And I think there's our contact information. So please take it down. Send us an email. We'd love to hear from you guys. And we encourage you to, connect with us through MAFP. We're also involved in ASAM. I'm involved in CMDA. There's plenty of opportunities to get involved in advocacy, get involved in education, and get involved in treatment. Thank you so much.
Thank you, Kurt and Kento. And Bill put the SurveyMonkey link for the evaluation in the chat. And we really appreciate you giving feedback. And we hope to see you at our next one in next month.
Thanks all.
All right. Thank you, guys.
Thank you. Bye-bye.